Right, thank you very much for these nice words. Good afternoon, everybody. Sorry, it's not going to be in German. I can do that in French if you like, but I guess English will be much better. So I was basically, I knew I would speak after Thomas, so the idea was really to show you what are the good news that we had in metastatic hormone-sensitive disease and then switch to when these treatments do not work anymore and what we should do when actually the disease is now castration resistant. So the usual name for that is sequencing, which is actually a name I do not like very much because it necessarily means that you're going to use one drug after the other one forever. Well, if it's forever, it's a good thing because it means that the patient is alive. But unfortunately, it's not necessarily forever because if you just sequence, most of the time your next treatment will not work. So I much prefer choosing and try to identify who should get a drug, who should not get a drug, and do we really have level 1 evidence to sequence when we have to sequence. So my disclosures, participation to boards or symposium, and this money doesn't go to me, it goes to my institution. So this is basically the current situation in terms of approval, or at least if it's not approval, where phase 3 trials were conducted and were positive. So basically this is the natural history of the disease. You basically have two situations. One is failing a local treatment and then things tend to deteriorate with PSA relapse, disease developing castration resistance, then metastasis, etc. Or the second situation, which was already covered by Thomas, which is that of the de novo metastatic disease. And you'll see basically in blue the drugs that we had for use 10 years ago, and then in red all the drugs that came in the last decade, which is really showing you the progresses that we've made. Of course, all these drugs were first developed in the last stages, but as you all know, they're now moving upfront to various early indications. So when you think about sequencing, you have to think about what the patient has received already. And again, this is clearly changing. You've heard from Thomas that we're now using Abiraterone and docetaxel in the M1 castration-sensitive setting, which means that the way we're treating these men, castration-resistant, should be different, of course, because those were standard of care just a couple of years ago. So let's see how we can think about this question. So if ever we are using drugs early for castration-resistant, castration-sensitive disease, of course, you will debate whether, and this was already done, whether we should use early sustained hormonal therapy with Abiraterone and tomorrow apalutamide and enzalutamide, or should we use docetaxel? Obviously, my preference would be for now to use hormonal therapy. This is personal opinion, but this is really because the hazard ratio that we saw with the next generation hormonal treatments were actually much more convincing, approximately a 35% reduction in the risk of death, as compared honestly to less than 20% reduction in the risk of death in the updated analysis that we saw, for example, you just presented Stampede. But whatever your decision, docetaxel or Abiraterone, when the patient progresses, you have to make a decision based on that. So what data do we have for these men? Well, actually, we don't have much data for CRPC in men who have received upfront docetaxel or Abiraterone for castration-sensitive disease. This actually comes from our French GETUC 15 trial, where we randomized the role of docetaxel in M1 disease. And we looked also at the data for subsequent treatment in castration-resistant disease. And what we saw was that if you're treating the patient classically, the way we used to do it 10 years ago, so ADT alone for castration-sensitive and then docetaxel for castration-resistance, docetaxel works. We know that for almost 2 decades now. Now, if you've been using ADT plus docetaxel upfront and you're now using docetaxel again, so re-challenge for castration resistance, it still works, but probably less, which of course makes all sense. Part of the disease is already resistant to chemo, or at least to docetaxel. This is what you're seeing here. Now, what about the use of abiraterone or enzalutamide, again in the scenario of a man who had already received chemohormonal treatment for M1 castration disease, sensitive disease, sorry. Well, actually, we don't have much data, but the one we have seems to be reassuring with a quite potent efficacy in terms of response rate, but of course, this is not randomized data. Again, those are all our own data from France, and similar data were also reported from the charted analysis. So again, if you've been using docetaxel upfront, it means that at least you'll have a second shot at resistance with abiraterone or docetaxel. Now, having said that, in the last 2 years, we've also changed the way we're treating patients with non-metastatic castration-resistant disease. Again, a man with a rising PSA, no detectable disease, at least by bone scan/CT scan, and we now know that 3 drugs are postponing the time to metastasis or death: apalutamide, enzalutamide, and darolutamide, with a very clear difference. But what we don't know is what is next, because these treatments are not curative, and eventually, and this is what is shown here, for example, patients will develop metastasis and they are castrated resistant. So what will be the efficacy of subsequent treatments? We just don't know at this time. I strongly suspect that switching from an AR axis targeted drug to the other one will not work. And I will come back to that because this is what probably we already know in CRPC. But of course, we don't have data, and hopefully we will have them. Now, moving to the more classical metastatic CRPC stage. What do we know about sequential? So next drug after one you've been receiving. And the first question is really, should we still use the old generation AR-targeted drugs, bicalutamide, nilutamide, maybe estrogens, maybe steroids, etc., before moving to abiraterone or enzalutamide? And we do have level 1 evidence regarding this question. 2 randomized trials were conducted. Early CRPC men, almost 400, asymptomatic, no previous chemotherapy, and they were randomized to get a next generation AR-targeted drug versus an old generation bicalutamide. Progression-free survival was a primary endpoint. Very clear difference. If you're looking at PFS, there's no discussion. Enzalutamide, probably true also for abiraterone, are much better as compared to bicalutamide, less than 6 months versus almost 16 months in terms of medians. Hazard ratio is 0.44. So very clear difference. Second, randomized trials, including also some patients with M0 CRPC on top of men with M1 CRPC, same data. 6 months or less, 19 months or more. So very clear difference. If your goal is really to get progression-free survival, we should just forget about bicalutamide and the old drugs and move directly to the next generation. I guess perhaps more convincing, at least to me, is when you're looking at quality of life data. Because here again, they are supporting next generation treatments instead of old generation. Because PFS you might really discuss, and of course because PSA is always somewhere, taking its place when it comes to PFS in prostate cancer, so you need to be cautious about PFS. But this quality of life is probably more convincing. The next question regarding the sequence question is what you do when the patient has already failed abiraterone or enzalutamide. This is obviously a key question. We're using tremendously dosed agents, and of course we know they're not curative. And this slide here is showing the bad news. The bad news is that the cross-resistance between these 2 agents is very high. If you're looking at men who receive enzalutamide post-abiraterone, the response rate is just about 5%. Ridiculous, truly. Now, if you're looking at men who receive enzalutamide after abiraterone, it's perhaps a little better, but still not really good, about 20% or so. And typically, it doesn't last very long because response is not everything. You need also to look at the duration. So perhaps generally speaking, we should stop sequencing these two agents. Having said that, many people, including me, have sequenced these two agents in the last 5 or 10 years because this is what we had, of course. And because it's much easier to discuss with a patient switching from a pill to another pill than having to say, well, I'm going to go, you should receive chemotherapy or something else now. Thanks to the Canadians, we do have randomized data from Abiraterone and Enzalutamide. And what they showed was that first line, if you're comparing the two, they're very similar. But actually, if you truly want to sequence the two agents, it seems that using Abiraterone first and then Enzalutamide does a slightly better job, at least in terms of the second progression-free survival based on PSA. So be cautious, it's not clinical stuff. And let's call it a trend for overall survival. But again, I think truly the main message is that for the majority of men, we should not sequence these two agents. Now, the good news is that taxane seemed to remain active in most men who were pretreated with Abiraterone or Enzalutamide. This is a waterfall plot, and as you probably all know, all those boxes, the blue boxes going down, show patients responding, while all those men are unfortunately refractory, chemo-refractory men. So you can see visually that there are much more patients responding to taxane, and again, they had all progressed while on Abiraterone. So the Taxel seems to work, but we don't have phase 3 evidence because it's an old generic drug and no one wanted to randomize that. Cabazitaxel, which is used post-docetaxel, but also post-Abiraterone and Enzalutamide, actually works. And we know that for a while. This was published 5 years ago, so the data were actually obtained even earlier. And you will see here that most men who had already progressed on both docetaxel and Abiraterone derived some benefit from Cabazitaxel, while just a minority of them were refractory to Cabazitaxel. So actually, in the last 5 years, based on this evidence and similar experiences, we should have used Cabazitaxel probably much more. But that was not really the case in many countries, again, because it's easier to switch from abi to enza than to have to sit down with the patient and say, well, probably it's time to go to chemo again. So this is why the CARD phase 3 trial was conducted, truly to convince the non-believers, because we actually already had non-randomized data and quite strong, I believe. So CARD was a trial for men who had failed at least docetaxel and one AR targeted agent, either Abiraterone or Enzalutamide. And these men were randomized, so it was basically a 4th-line treatment because this was on top of ADT. They were randomized to receive either Cabazitaxel or the second AR axis targeted drug, Abiraterone if you were on Enza, or Enza if you were on abi on the first place. Primary endpoint was radiographic progression-free survival, and as you can see here, and this is quite brand new data, actually Cabazitaxel does a much better job as compared to the second AR axis targeted agent. Has a ratio 0.5, 0.54. So clearly much better. You might say, well, but probably it's different if the patient has received abi or enza first, etc. Actually not. Regardless of whether you've been using abi or enza first and then enza or abi second, Cabazitaxel remains better than the second AR axis targeted agent. And this is not only radiographic progression-free survival, this is even overall survival, as you can see here. Hazard ratio 0.64. How often in oncology do we have a treatment in the 4th-line setting of an epithelial cancer showing overall survival improvement? I can't remember much examples, to be honest. Here we have one. So I think it's very important to remember. Now you might say, okay, this is all nice. It was all about sequencing and trying to be better in all of sequencing, one drug after the other one. But knowing the mechanism of action of these drugs, perhaps we should pull them together. And Thomas already discussed that for the M1 castration-sensitive disease. Should we use triplet, for example? And it's the same question, actually, in castration-resistant. Should we combine? Well, here I have to say that the previous decade was not really a success. And this is a long series of phase 3 trials testing your next magic or my next magic new drug on top of docetaxel randomly. It really didn't work. Thousands of men were randomized for basically nothing. Probably not because the wedding with docetaxel is not possible, but much more because these agents actually were not very potent, which means that the rationale that we had when we embarked in a phase 3 was not strong enough. And it's true, actually, that the pharma industry is usually keen to test, to spend money, and if it's negative, it's negative. But I think it's all a role to sometimes tell them we should not, because truly, honestly, in the retrospect, a big part of these agents should not have been tested randomly. So I think it's a lesson for the future. Also, even when you have two drugs with phase 3 evidence for efficacy, we should be very cautious before pulling them together. And the next slide is going to show you an example for that. In the one hand, you have Abiraterone, at least 3, now 4 randomized phase 3 trials showing overall survival. It's an active drug, no discussion. On the other hand, you have radium-223, 1 phase 3 trial showing overall survival also. When you think about it, it made all sense to combine. We know that radiation and ADT are good partners in localized disease. There is a synergy. So it made sense. So the phase 3 trial was done, and everybody, including myself, thought that there was a good chance for Abiraterone and radium combined to be better than Abiraterone. Number one, it's not the case. And number two, it's actually worse. We're arming patients with a combo, and clearly arming. This is fracture incidence. And actually, we haven't thought about it. But when you're using ADT, you're depleting your bone in calcium, in mineralization. We know that, and we're trying our best sometimes, not always, to prevent it and to treat that, osteoporosis. If you're using Abiraterone and corticosteroid on top of that, what is the effect to the bone? We actually just don't know. This was, as far as I know, never studied. It sounds crazy, again in the retrospect, but we don't really know what is the exact impact of Abiraterone against osteoporosis. And if you're irradiating a frail bone with radium, it breaks. And actually, most patients who develop fractures in these trials develop osteoporotic fractures, more than pathologic fractures. So again, very important lesson for the future. We should not combine in all the clinic 2 treatments that we like. Just because we like them, we need stronger evidence to do it. Because sometimes not only it's not better for the patients, but it's worse. And actually, it comes back to bone, because metastatic prostate cancer is really a bone disease. And we know for at least a decade now that we have agents with hyaluronic acid or denosumab that can prevent or limit the incidence of bad problems toward the bones. And for example, this is spinal cord compression. If you're using nothing, almost 10% of your patients will end up on a chair before dying. Now, if you're using the hyaluronic acid, about 4%. Denosumab, slightly better maybe, 3% or so. But still, it is better than nothing. And actually, based on the poor and bad ERA-223 experience with Abiraterone and radium, our colleagues from EORTC leading the P3 trial, which is testing randomly Enzalutamide plus or minus radium-223, of course decided to amend their protocol and to be extremely careful with fractures. So not only the IDMC of the trial meets every 2 days, probably, to look at fractures and make sure that there's no excess in the experimental arm, but also the investigator amended the protocol to make denosumab or zoledronic acid mandatory after, again, the ERA 2-3 data were public. And this is data that was shown 6 months ago at ASCO by Bertrand Tombal, who's one of the co-PI of the trial. And actually, I think it's very important for the practice. If you're looking at this blue curve here, that's the incidence of fractures in men receiving enzalutamide plus radium. It's crazy high, 50% almost at 2 years or so. Half patients have a broken bone. Now, if you're looking at enzalutamide alone, it's still super high, almost 20% at 2 to 3 years. It's really, really too high, not acceptable. Now look at the red and the black curves. Same arms, enzalutamide plus or minus radium, but with the use of denosumab. 0%, or maybe one patient here at 27 months. It really seems to work. So I really think that we should think about the way we're using bone-protecting agent in castration-resistant disease. Either we thought in the last decade, well, now that we have abiraterone, enzalutamide, cabazitaxel, etc., we don't need any more of these drugs. But actually, it's the opposite. We really need them for the sake of all the patients. Now let me move to the last part of this talk, which is not really about sequencing. It's trying to personalize all the treatment and just not, giving, say, cabazitaxel that I just showed you, or abiraterone or whatever, to all patients in the same situation, trying to be smarter and get some information from their biology. Not only, of course, from their clinical parameters, because we're all doing that, I guess, in our practice. Beautiful paper reported already 5 years ago. It's all about genomics, but genomics for the dump. So easy to read, you won't sleep on it. It's really very nicely explained. And it's trying to show us what are the main drivers of a disease when the disease has already failed next generation AR targeting abiraterone, enzalutamide, and taxane. And bet what? What is the #1 driver? Androgen receptor. Again, even after abi or enza. That's the #1 driver of a disease. #2 driver, the PI3 kinase pathway, which means that for the first one, if we're able to invent a super abiraterone or super enzalutamide, we may make another progress. Same for the PI3 kinase pathway. There are drugs that can perhaps help all the patients. Third, DNA repair, also emerging as something big in some patients and some others. So let me try to review what we have to target all those and maybe some others. AR targeting. You know probably the story of the AR V7 variants. There are pros and cons. It's complex biology because it comes together with the amplification of the AR. But if ever the story is true, we need to invent drug targeting the N-term part of the androgen receptor, not the C-term part, as all drugs that we're using are doing. Enza binds to the C-term part, bicalutamide, APA, daro, all these drugs, and abiraterone indirectly. So we need to invent those drugs. Phase 1 trials are currently ongoing. Now this is about the receptor. What about the ligands? It's super complex biology. We're full of hormones, full of them. And actually, men and women are pretty much the same, to be honest. Really small details. We all have, as you all know, estrogens and testosterone. And actually, we don't know for sure, but that's another debate, what exactly estrogen or the ER does in prostate cancer. But anyway, let's focus on the AR activation. You all know that testosterone and DHT are the two most potent ligands to activate the AR biology. But there are also a bunch of other androgens that can bind to the AR. You might say, well, fine, we have abiraterone that can prevent the making of these hormones. It's true, but it's only partially true. Even after abiraterone, if you're looking in your cancer cells, at the ratios of androgens, you still find some. Either because it's not a perfect drug, it's not inhibiting completely the enzyme, or maybe because there are other enzymes that we don't know that can circumvent and make some androgens even when CYP17 is being targeted. Which means that, and on top of that, those are androgens. But on top of that, almost all these hormones here, which are not androgens, progesterone, corticosteroids, in some situation can bind to the androgen receptor and stimulate it due to mutations. Which means that at least in some men, we may need to be brutal and just try to shut down all hormones right after the cholesterol, targeting the first enzyme, which is CYP11, which is making all the precursors. You might say I'm crazy because we need hormones to survive, which is partially true, craziness and hormones to survive. Those are, for example, key hormones, mineralosteroids, but also corticosteroids. But we know how to replace that. We know how to treat Addison disease for a long time. So one thing you might consider doing is shut down the hormones and give a small amount of the hormones which are needed to survive and see whether it works against prostate cancer. And this is currently ongoing in phase 1 trial with the ODM-208 and ODM-209 compounds. We'll see. Second pathway, the AKT and PI3 kinase pathway. About 30% of men, mostly those with aggressive disease, have loss in PTEN, which means that this pathway is constitutively activated. And it's talking, as you can see here, together with the AR pathway. If you're targeting one, the other one will be stimulated, and vice versa. Which means that in these men, we should target both at the same time. This was actually done in a randomized phase 2 trial. And you will see that for men who receive abiraterone alone, there's not much difference as compared to men who received a combo with an AKT inhibitor when PTEN is normal. Now, for men with PTEN loss, it's another story. The combo seems to be a much better job as compared to abiraterone alone. And this finding was observed with 400 milligram dosing, but the same was actually achieved with 200. Efficacy, no efficacy. Which means that we might really have a good candidate for personalized medicine here. The phase 3 trial is now completed. We're waiting for the data. So again, we will see. Third pathway, DNA repair. We thought that really DNA repair was a big thing for breast cancer and ovarian cancer. And actually in the last 5 years or so, we saw clear data indicating that about 10% of all the patients with advanced disease have germline BRCA2 or other DNA repair genes mutations. And on top of that, an additional 10% have somatic, so in their cancers, not in all their cells. 10 plus 10, 20% of the total. It's quite big. We now have also level 1 evidence that it's a potential target for treatment. This is the profound data that came out some 3 months ago or so at ESMO. And it was really testing whether PARP inhibitor would do a better job as compared to a second hormonal agents in men who had already failed abiraterone or enzalutamide, and for most of them, docetaxel. So one cohort was that of the most frequently observed genes, BRCA2, ATM, and BRCA1 in this order. And the second cohort was about rarer genes. This is a positive phase 3 trial. RPFS was a primary endpoint. And as you can see here, there is a very clear difference. Hazard ratio is 0.34, almost a 70% reduction in the risk of progression. And believe me, we're talking about bad cancers here. Those are aggressive cancers, very symptomatic. And talking about symptoms, symptoms were clearly prevented with the PARP inhibitor as compared to the second AR-axis drug. Actually, overall survival goes the good way, and it's very likely that overall survival will be shown as being different. And it's really impressive because the crossover occurred after 3 months only for most patients, because patients could cross over in this trial, which means that not only PARP inhibitor work, but it could well be that earlier is better. Now, a big question is really, does this data apply to all gene alteration or only some of them? And I don't have a final answer to that question. Obviously, BRCA2, I think this is very clear difference, and all the phase 2 programs show the same. So I think there's no discussion. But for the rest, they're much rarer, and there are some conflicting data. So we need even more data. And here, probably some academic work needs to be done. But it's good to see that PARP inhibitors will hopefully be on the market very soon. What about these two ones? Those are the two stars of oncology, the antigen-presenting cell and the T lymphocyte, immunotherapy. We're talking about immunotherapy every day. You'll hear right after me, Laurence, about kidney. It's obviously a revolution in kidney. But what about prostate cancer? Well, actually, it works. But it works only in some patients. This is one of all the patients, 2011, horrible cancer, progressing after everything. PSA was 120. He started on Ipilimumab, no more pain, no more opioids, bone scan normalized, PSA from 120 to 0, and it's been continuously 0 until today. And you will never, I guess, see this phenomenon with any other treatment I've been discussing today. The problem is that the trial was analyzed a bit too early. So this is the longer-term analysis. P-value for overall survival is significant, but this is regarded as post-hoc. When the trial was first analyzed, we were approximately here. And because of this phenomenon, when we are arming some patients with immunotherapy at the beginning, it was negative, with a p-value of 0.053. Horrible. Just 1 or 2 additional months, and it was positive. But medically speaking, it means that the patient I just showed you is not unique. There are some other patients clearly benefiting in the long term. And we will soon report the very long time data, and it's clearly confirming what I'm showing here. What about PD-1 and PD-L1? First phase 1 trial, no response in prostate out of 16 men. Everybody said, prostate is a cold cancer, we're not going to go there. And then some people in the West Coast re-challenged that in the academic world and showed that 5 men clearly benefited from immunotherapy, and sometimes tremendously, PSA 2500 down to undetectable. And actually, most of these men, I think 4 out of 5, are still in complete remission right now. So the same story. The question is, who are these men? Or what is the biology? And until very recently, we had no clue. It's just starting. First, 2 to 5%, actually more 2 than 5, of all the patients have an MSI phenotype, MSI high phenotype. And these men seem clearly to benefit from immunotherapy, which question whether we should screen all the men for MSI status. Second, and this was just shown a year ago, approximately 6 to 7% of men with advanced disease have CDK12 loss or inactivation. And actually, this is associated with neoantigens and very likely sensitivity to immunotherapy. 2 out of 4 men responded to immunotherapy in this first program. And of course, confirmation is ongoing. Third, if you're combining Ipilimumab with nivolumab, some men will clearly respond, clearly not the majority, and of course there is the toxicity. But it seems that tumor mutation burden might be a predictive factor. Again, this is brand new data. We're waiting for confirmation. So do we have anything else? I told you about next generation AR targeting, PARP inhibition, maybe immunotherapy, AKT targeting. Yes, PSMA, obviously. And I guess many of you actually, I think, are German here, and you know probably much more than I do about PSMA and PET PSMA, which is broadly available, but also PSMA targeting with PSMA lutetium. And it works very, very clearly. We're now waiting for the confirmation in phase 3 trial, which was completed last year. Hopefully, maybe at ASCO this year, we'll have the first phase 3 trial of PSMA lutetium. And PSMA is not only about lutetium or radioisotopes in general, but it can be a target for other things, BiTEs, etc., etc. And this is also ongoing. Finally, we may have missed some very simple questions. When you think about it, metformin, aspirin, statins, a bunch of data supporting activity in vitro against prostate cancer, clear rationale to prevent cardiovascular problems related to hormonal therapy, and also in epidemiological analysis of phase 3 trials in diabetes and cardiovascular, less prostate cancers, less lethal prostate cancers. So that's a rationale, actually, to test these all drugs. And this is what we're going to try to do right now, and actually we're trying. Stampede has a metformin arm, which is enrolling rapidly, and we just started the peaceful phase 3 trial, which is very simply randomly assessing the role of aspirin and statin on top of all treatments you like to use. So we'll see. But coming back to targeted agents and personalization of medicine in prostate, look what we have now. We have clear evidence that MSI-high predicts for immunotherapy. We have clear evidence that DDR genes predict for PARP inhibitor efficacy. But there are some good candidates. PTEN loss and AKT inhibitors, AR mutation and some new ligand inhibitors, CDK12 immunotherapy, PSMA PET to select best patients for PSMA targeting. We're probably just now changing completely the field, moving for treatment for all comers to treatment for Mr. Smith or Mr. John or Mr. whoever, which is really what we should do. Conclusion, early treatments is becoming more and more a reality, with phase 3 trial showing that we should do it. Sequential treatment still is our routine treatment, but I think we've made progresses to better understand which treatment we should sequence and not sequence necessarily all drugs. It's useless for patients, it's sometimes toxic, it doesn't work in all patients, and it's expensive. Remember about the cross-resistance between abiraterone and enzalutamide, and remember that taxane remain active post-Abiraterone or enzalutamide. And finally, biomarker-driven medicine is just arriving right now. Thank you very much for your kind attention.